and welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I am your host, Rebecca Sapp. I am a board-certified allergist and immunologist and a fellowship director who always enjoys learning more about the exciting field of allergy immunology. Our podcast series will use interviews with thought leaders from the world of allergy to keep you up to date on new developments and review core topics. Today's edition of our Conversations from the World of Allergy podcast series will focus on dissemination and implementation sciences and an example of this in asthma. We are pleased to welcome Dr. Stan Szefler. Dr. Szefler is the Director of Pediatric Asthma Research Program at Children's Hospital, Colorado. He is also a professor of pediatrics at the University of Colorado School of Medicine. He is the co-principal investigator for the Denver site of the NHLBI PRECISE network that is focused on precision medicines for severe asthma. And his research has identified key biomarkers and asthma characteristics that are associated with asthma exacerbations and the response to asthma therapy. Dr. Szefler, thank you so much for taking the time to join us today.
Thank you, Rebecca.
Is it okay if I call you Stan?
Yes, it is.
And I'd like to start just by getting to know you a little better. Could you tell us something about yourself and maybe something you like to do outside of medicine?
Yes, as you said, I'm a professor of pediatrics at the University of Colorado. And prior to that, I spent 30 years at National Jewish Health, where I was the director of pediatric clinical pharmacology and also the Pediatric Trial Center. I relocated to Children's in 2013. I trained in clinical pharmacology and allergy immunology in Buffalo, New York. Aside from that, when I get time, I try to do a lot of outside reading. And one of the topics of interest is Shakespeare and what was going on at the time. I like to think I met most of the Shakespeare characters in real life. So it's kind of a fun hobby of mine.
Absolutely. So you mean like what's going on around the time of Shakespeare's writing?
Yes. And the characters are interesting because they reflect a lot what you see in real life. The Hamlets, the King Lears, the Julius Caesars. Kind of a fun thing to relate it.
Oh, absolutely. And what made you choose allergy immunology as a field?
That was interesting in how it happened. I trained initially in pharmacy school before medical school. And I got very interested in pharmacokinetics. And at the time I was completing residency, I met Dr. Elliot Ellis, who was the premier pediatric asthma specialist at the time. And when I met him, he had recently relocated to Buffalo in the mid-70s, and he was chair of pediatrics at National Jewish. So I developed an interest in steroid pharmacology, and Dr. Ellis encouraged me to join his section in allergy and immunology, and we pursued various projects along the lines of asthma therapy. So I'm forever grateful. He was a big part of my career development, and we kept in contact for a long time.
It's wonderful to have those mentors that stay with you for so long and really encourage you in the field.
Exactly.
And so steroids have been around for a very long time. Do you think we still have more to learn about steroids?
Yes, particularly, as things shifted away from systemic steroids to inhaled steroids. We still have things to learn about the various products and the delivery and safe doses, and a lot of other things are still in an area, and adverse effects still in an area that we have to understand a little bit better.
Absolutely. And so good that we have so many new medications that allow us to get beyond steroids these days, particularly in asthma.
Yes. There's been, since I was at National Jewish in the 80s, there's been really an expansion of the number of the type of drugs we have available.
You were a member of the work group called applying the dissemination and implementation sciences to allergy immunology. I think many of us don't necessarily know what dissemination and implementation sciences are. Could you explain what those are?
Yes, I'll try to do it briefly, but Dr. Sharmaleen Nayanis and Sujani Kukumana did an excellent job in leading this work group, and the publication was in the October 2024 issue of Journal of Allergy and Clinical Immunology, so people can get a deeper feeling for it. But basically, what's done in implementation research, and particularly when you add the dissemination component, it's to try to understand how a evidence-based program applies in various settings. And so you want to get a feel for what are the successes, what are the challenges, what are the barriers in doing that kind of work. And they have a particular framework and different outcomes. So the framework, one of them is called the EPIS framework, and it really involves exploration, planning, implementation, and sustainment. And so you go through those various phases in setting up the study, conducting the study, and then looking at, can the intervention or the program be continued after the study is done? So that's one area that makes things a little bit different.
So it's really more about the application of our research to the real world setting. Would you say that's accurate?
Yes, that's very accurate in terms of, a lot of studies are done in large urban settings. And the question is, do they work in the mid-sized cities that are not connected to an academic center, or do they work in a rural setting where their resources can be very limited? So that's what makes it very interesting to do these kind of studies.
Absolutely. And in the report, I was kind of struck by how few research discoveries actually make their way into the clinic. So certainly less than 50%, and that may be in the academic setting, let alone getting into resource limited settings. What do you think are the barriers that we see in bringing research innovation into clinical practice?
Some of it is, where the study is published. Is it in a high profile journal like New England Journal of Medicine or JAMA or JACI, where the appropriate clinicians can read the study? We're fortunate in that we have national asthma guidelines and the Global Initiative for Asthma, and they screen for these studies, and actually the NIH has supported some of these studies. But a lot of the attention tends to be on the therapeutic elements, but there's other elements of care, like programs such as the school program that I'm involved in, that may not receive the attention and the high profile recognition. And so they can kind of get lost along the way if they don't have advocates moving them forward.
And do you think implementation sciences can really help to address health disparities as well?
Yes, I think so. It's an emerging area, and it's been particularly helpful in cancer chemotherapy and HIV management, because you really start to understand what are those variables that may impact the movement of a study to clinical practice. And as I look at it and gain more experience in the area, I think it's an approach pharmaceutical industry should take in terms of developing the new drugs. Take the asthma biologics. If they started out thinking, who does this apply to? Where should we direct the studies? And what will the uptake be? I think it would be an interesting process to carry it on beyond efficacy into the world of effectiveness and extended application.
So how do you think the outcome measures are different in implementation sciences than they might be in the traditional research study that you read about?
Yeah, that's a very interesting component too. And I have to admit, I took the deeper dive into implementation science about 8 to 10 years ago. So I'm still learning, but the outcomes are quite different when we do say a therapeutic intervention study, say an asthma biologic. We're looking at exacerbations. We're looking at symptom management. We're looking at an improvement in pulmonary function. With the dissemination science, you're taking a program and looking at its reach. What's the uptake in certain populations? Can you keep that program going and maintain the fidelity of it? How well is it adapted in certain settings? And then also, as you complete the study, again, can it be sustained in that setting after the funding is gone? Can you leave a mark and the program continues in all or maybe some of its components?
So it's really looking about how it makes its way into our health system and how different groups of patients are able to get the medication, take the medication, respond to the medication. It sounds like.
Exactly, exactly.
And so the goal of the work group, what was the goal of the work group in this case?
I think here, we communicated on some levels of things that we were doing. And the group felt that this is such an interesting and important area, particularly as we're trying to establish health equity, that more visibility um, for our colleagues would be important, particularly for young investigators developing their career. There are now centers within the universities that have outcomes related research, that it would be a good thing for them to get involved in and learn the various components of how to do these studies. So that visibility plus similar to things like I mentioned in cancer, there's a huge program in the Cancer Institute that's focused on implementation science. The Heart Institute has endorsed it, but there really hasn't been kind of a rise to that level in our allergy societies and respiratory societies. So we'd like to see more awareness and more application.
I wanted to focus now on the application of the implementation science, particularly in asthma. You've been involved in a number of school based asthma management programs, which is often abbreviated SAMPRO. We do love a good acronym in medicine. Can you tell us how you got involved in school based asthma programs?
Yeah, and in terms of SAMPRO development, I was doing work in the school-based programs for about 10 years before that. When I was at National Jewish, we kind of got going in the area. And SAMPRO kind of developed at a breakfast meeting that I had with Dr. Robert Lemansky. And he asked me what I was doing in terms of my work. And I told him about what I was working on. And he thought it was really a good idea. And he was the incoming president. And I said, why don't you put this on your platform? And he did. And he did a tremendous job in increasing the visibility and establishing SAMPRO. And they have a lot of good materials to draw on. And food allergy joined shortly after we had our focus on asthma. And we developed a nice collaboration with the National Association of School Nurses as well. So it's been fun. I've been involved in the development of the school-based program in Colorado for about 20 years now.
What do you think the benefit is to having a school based program?
Yeah, I think about that a lot. And, in the clinic, we see people who come into the door. But outside the clinic, there's a lot of children that are not getting regular care and that use the emergency room for their periodic exacerbations. And then there's other children who are in seeing a physician, but their asthma's not well controlled. So we focused our program on schools where we knew there was a need, and it's easy to identify those schools. And what we wanted to do was identify those schools, assess the level of control, and then move them, educate them, and move them into regular care. So that's been the major goal of what we've been doing. The nurses in the schools tend to pick up the kids that are, wheezing after exercise or missing a lot of school. They can really put a lot of information together.
And I think that one of the most important things I imagine in a school-based program is just managing all the communication between all the stakeholders in the program. You have the kids and parents, you have the nurses, you have the physicians. How do you manage that? How do you bring together all the stakeholders and keep that communication open?
Yeah, that's kind of the fun part. For me, being in an academic center and, discussing high profile studies, it's nice to go out into the community and meet some of the people and realize how dedicated they are to helping students. And it's kind of called the circle of support. And if you can kind of strengthen the communications between, say, the school nurses and the clinicians can gather a lot of information, and we call it building bridges, because in the way I look at it, we have a lot of silos in a healthcare system, and if you can get groups communicating with each other, you can really kind of develop a two-way street in terms of support.
And how do you develop that communication? What methods do you use?
It's kind of funny because we have all these electronic medical records, and sometimes the communications from the schools to the providers is by fax. And so we've been bringing that level of need, say, to our hospital, and they've developed ways to communicate, one through the action plans, but also through like read-only opportunities in terms of the medical records. And then also encouraging the nurses by educating them, they can communicate with the practitioners as well when they see a problem. And what we're trying to develop in Colorado is designating schools as Colorado asthma-friendly schools, setting up training programs for the nurses, for their assistant staff in the schools. So it's kind of building these different levels of cross communication and comfort in communicating with each other.
What about parents? How do you involve parents in this?
With the parents, we have asthma navigators. They're community health workers that are particularly focused on asthma, and they develop trusting relationships with the parents, and also work on educating them about what is asthma, why do you need regular therapy, what are the triggers, how do you manage triggers, and that kind of brings them into a closer relationship. Unfortunately, in the office, you tend to have only 15 minutes, and these parents, some of them don't know what asthma is. You really kind of need to sit down with them for a longer period of time and educate them in their own language as well. So, initially Spanish was a challenge, but we have bilingual asthma navigators. And now with the immigrant and refugee population, we have many languages to contend with.
What kind of training do the asthma navigators have?
We have in our group, Melanie Gleason is a physician assistant, and she coordinates the training of them. And we have kind of set training that we've established that's kind of a core level to get them integrated into what is asthma, how to communicate, how to assess for social determinants of health, how to understand the resources in the community. Our Colorado Department of Health and Environment, CDPHE, has courses and certification for community health workers. So we combine both of those elements.
And I imagine for this to work well, you really need to have a good relationship with the community. How do you establish that and maintain it?
It's an important component. In our bigger study, we have one study that's funded by CDPHE that's Denver-centric and more outreach, community-based participatory research. And then we have another one that's funded by NHLBI that is really the dissemination implementation component. And there, in going into new cities, new regions in Colorado, we developed community advisory boards consisting of parents of children with asthma, school nurses, public health officials, representatives, and they give us input. We come to them with reports, and they give us input about what could work in their community and what may not work.
And what kind of outcomes are you looking at?
For us, it's in our study, in the replication study in Colorado, it's called a T2 hybrid design, and so we look equally at efficacy and also at the implementation outcomes, like the reach, like the adaptability, the fidelity to the program. And also what we're concentrating on now is what can we do to help sustain the program. One of the reasons for that is there's a lot of turnover in staff. School nurses move from one school to another, or they may move to another region. So we have to have some kind of an anchor for them to be able to continue what we're trying to do.
And how do you think you could fund a program like this if you didn't have a grant from like an NHLBI? What are the ways that you could fund and sustain a program like this?
That's an excellent question, and that's actually what I'm really focusing on right now. Fortunately, in Colorado, we have the Colorado Department of Education Nursing Services. So one of the things that we've done is really become part of their working group and the teaching element. And so the tools that we're developing, like one of them is a dissemination playbook, and others are various slide materials and what they call community learning opportunities, couples. And so all of those elements we're trying to build into a system where we could maybe walk away or continue to lead it and have those components continue to kind of elevate the bar. It'd be really great if our hospital would support it, and we're looking into that, or the university, as we kind of look into ways to support our communities.
And what challenges have you encountered kind of in getting this set up?
Lots of challenges, and we've, for one part, our CDPHE grant is 3 to 5 year cycles. So you always have to innovate, and find ways to to kind of take the program to the next level. And so that's kind of a challenge, getting the groups together, getting the support of a new school district and the schools that are involved in it. The other thing I think recently, with everything going on, it's building the parent trust, that this isn't some program that's not worth their time, or because they think their child is in good control, or records are going to be released to someplace outside the school. So you have to kind of build up those trusting relationships.
Have you noticed changes at all? Particularly with the COVID pandemic, have you noticed changes in the ways that either parents or schools approach this, kind of pre and post?
Yeah, definitely. We kind of, in the hospital, talked a lot about telemedicine pre-COVID. And it was kind of like taking time to develop. And then COVID came and social distancing. And then within 2 weeks, telemedicine took a huge leap. And so we had to do the same to adapt to that and switch to, Zoom visits for home. And in some ways, it was a two-way street because we learned from the hospital and they learned from us in terms of ways of communication. I think the other challenge is sometimes getting translators in the school for the different languages. And also the social determinants of health takes more time, for the navigators to work with the families to understand the resources in the community and to direct them in those areas.
And you probably really have to tailor both the kind of assessment and monitoring of social determinants of health to the community. Would you say that's accurate?
Yes, definitely, because the resources change, the needs change. One of the things in the schools is you can kind of identify the students that need some assistance because the schools know if they need free and reduced lunch. They also know through the communications what their insurance support is. Is it Medicaid? And so those two variables that combined with asthma and their level of control gives you an idea of who needs extra attention.
And what are the lessons that you've really taken away from running these programs in the schools?
Yeah, one of the big lessons I learned from the very beginning is in kind of doing research, you don't do it in kind of a parachute manner. Jump in, get your data, and disappear. It kind of merges into a commitment and a long-term commitment, and so it kind of grows into a mission, and you have to treat it that way. And then it's really enjoyable working with people in the community that have different perspectives on things, and you have to kind of sit back and listen and take their advice. I was very lucky when I went to the Denver public schools. The lead nurse there was African American, had severe asthma, knew its effect on school absence, bullying, dropout, and so she was very supportive. And so that identifying those asthma champions are important. And then just having a vision and creating strategic partners in order to make it happen has been important.
Sounds like listening is such an important part of this, listening to those that are in the schools, the nurses, the asthma educators, to really know what the next steps that are needed are.
Exactly.
And have you been able to mentor kind of the next generation of people coming in, setting up these programs?
Yes. Right now, Heather DeKaiser, who's in our pulmonary program, is is working with me she was trained in implementation science, and I've been mentoring her in the area of digital health. And so now she's extending her work she's interested in public health. And so she's going to pretty much follow in my footsteps, along with the staff that I've trained. Melanie Gleason she's the physician assistant. She's been a huge part of the development of the program.
And are you seeing growth in these programs in other states and other places?
Yeah, again, they tend to be grant funded, and when the funds disappear, the programs are gone. But our model in terms of development was the Breathmobile in California, Los Angeles. At the time, it was Craig Jones who got that going. Stan Gallant, who's a member of the Academy, has kept it going. So the Breathmobile was really kind of a model for us. And that's a van that goes to the school and the students come out. In our program, I decided the navigators would go into the school and kind of become part of the school community.
And if somebody was interested in setting up a program like this in their community, what are the resources you would recommend they turn to as they got started?
Definitely communicating with the Academy in terms of SAMPRO and learning what resources are there. And then, exploring with the schools. It's fun to kind of go from the clinic and go to the local schools and just get a feel for what that's about. Talk to the lead nurse in the school, see their level of interest. And then kind of look into the funding possibilities. Sometimes it's through the Lung Association in the area or the Asthma Foundation, and see what their level of interest is in terms of helping to develop the programs in the community. And there's a number of people in the Academy. Tamara Perry is an example. And then there's a person in Philadelphia who have excellent programs. So there's people you can collaborate with and partner with.
I would love to see these programs spread. It seems like such a wonderful way to get physicians connected to the community and to people in the community who are actually have eyes on kids and what's going on with their asthma outside of just that 15-minute visit that we see them.
Yeah, it's, the success stories are really the thing that make you stop. We had one where a mother passed away and the father was left with 4 children. And the father knew almost nothing about asthma. And the asthma navigator really helped him understand it, connect him to resources. And we have a number of those success stories that, really ring a bell. They don't show up in the data when you kind of analyze reduction and exacerbations, but they're as or even more important.
Absolutely. I imagine those are the stories that keep you going and keep you in the schools and keep you doing this.
Yes, it is.
Well, thank you so much for taking the time to be with us today. Is there anything else you'd like to add in terms of advice or the summary of things that you found helpful?
Some of the things I mentioned before are the important area. I think the thing is to reach out. Don't try to reinvent the wheel by creating new action plans and new materials, teaching materials. There's a lot available that's already been well done, and people are willing to share it, including myself. I mentor a number of people around the country that are not only in asthma, but recently a person in hypertension management. So it's kind of fun to get to know other people, help them along in their career.
Well, I'll encourage people who are interested in learning more to maybe come find you at the upcoming meeting if you're going to be there, and hopefully we can continue to grow the programs.
Yes, thank you very much. They're welcome to contact me.
Great. Thank you. We hope you enjoyed listening to today's episode. As a reminder, this podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence-based information. Any question pertaining to one's own health should always be discussed with their personal physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board-certified allergists in your area. Use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at quadai.org. Please visit quadai.org for show notes and any pertinent links from today's conversation. If you like the show, please take a moment to subscribe to our podcast through Apple Podcasts, Google Podcasts, or Spotify so you can receive new episodes in the future. Thank you again for listening.